This topic is esophageal varices. What are varices? Well, when we say the word varices, this refers to any distended, tortuous, fragile blood vessels that develop within the esophagus. Before we talk about the pathophysiology of how varices develop, let's first understand how blood flow occurs from the esophagus and the stomach into the portal vein and eventually back to the heart. What we're looking at here are the veins associated with the esophagus, the stomach, and the liver. So again, veins are going to drain blood from the body and bring it back towards the heart in order for it to be reoxygenated and sent out through the arteries. So with this blood flow that occurs, we're getting the blood flow from the esophagus and the stomach, and that's draining into the portal vein. Normally, this occurs without any complications. However, if a patient has liver cirrhosis, this can lead to a fibrosing of the liver tissue, which enlarges the liver and can obstruct the flow of blood from the liver into the portal vein. The result of this is portal hypertension, and that hypertension can cause blood flow to back up into the stomach veins and the esophageal veins, causing this distension and leading to the development of those varices. As this pressure builds and increases within these veins, they can become more and more distended and fragile, and they can eventually rupture, which can lead to significant life-threatening upper gastrointestinal bleeding or hemorrhage. Patients with liver cirrhosis may not even know that they have esophageal varices. In fact, they can often be asymptomatic without any esophageal rupture. For patients with liver cirrhosis, it may be advised that they have an upper endoscopy to assess for the presence of the esophageal varices. When these varices rupture, patients can present with manifestations of hemorrhage. One of the main presentations is going to be vomiting bright red blood or clots, which is frank hematemesis. Again, this bleeding is going to be excessive and almost may even mimic an arterial bleed. Because there is so much bleeding that can occur, the patient is at risk for aspiration. If the bleeding is less, say maybe if only 1 or 2 blood vessels have ruptured, we may only develop that coffee ground-like emesis, or the patient may digest some of that blood, which can result in the development of melena. With any type of bleeding, whether it's small or large, we need to make sure that we're monitoring for other signs of hypovolemic shock, such as hypotension, tachycardia, or pale or cyanotic skin. Besides preventing hypovolemic shock, one of the most important things the nurse must implement is to make the patient NPO. We need to protect that airway to prevent aspiration and any breathing complications that can result from aspirating that blood. If the bleeding is massive, the client may even need to be intubated in preparation for surgery. In addition to protecting the airway, the nurse needs to implement interventions that are going to prevent that hypovolemic shock. Most oftentimes, the nurse is going to need to make sure the client has 2 large bore IV catheters in order to instill IV fluid boluses as well as packed red blood cells to maintain that blood pressure and improve perfusion. The nurse may anticipate an octreotide infusion. Octreotide is a medication that can vasoconstrict some of the blood vessels that surround the esophagus itself, which is going to help control that bleeding. Additionally, a proton pump inhibitor may be used to help reduce stomach acid and prevent any irritation of those bleeding vessels. This bleeding isn't going to be managed just by clotting alone, so the patient is going to be prepared for an emergency EGD procedure. Once a client goes for an EGD procedure, there's a number of different ways that the bleeding can be controlled, whether that's sclerotherapy, which is taking a medication and injecting it directly into the vein to control bleeding, band ligation, taking a rubber band and placing it around those varices to stop the flow of blood. In cases of significant bleeding, a patient may need a Senstaken-Blakemore tube. Now, this is a tube that is almost kind of like how you insert a nasogastric tube, except for the tube passes through the oropharynx. So this is an oropharyngeal tube that goes down through the esophagus, and once it passes through the esophagus into the stomach, a balloon is inflated to put pressure against those bleeding varices to stop the flow of blood and prevent any further bleeding.
This topic is abdominal aortic aneurysm, or AAA. The aorta is the largest artery in the body, and it carries a lot of blood from the heart out to the circulatory system. When there's a weakening in the wall of the aorta, a blood-filled bulge forms, known as an aneurysm. Because the aorta is so large and there's large amounts of blood pumping through it, there's a lot of force behind it. So this continuous force is going to increase the size of the aneurysm over time. Now, if we don't intervene, the aneurysm is going to continue to expand and can eventually rupture, resulting in hemorrhage or even death. AAA is diagnosed with an abdominal ultrasound or with a CT scan. One of the biggest risk factors for AAA is smoking. Over time, smoking is going to damage the vessel walls and make them more susceptible to aneurysm, and smoking is also going to increase our blood pressure, known as hypertension. Whether hypertension is caused by smoking or another means, hypertension in general is going to increase the risk for an aneurysm because there's extra strain on the heart and vessels. Clients with atherosclerosis have plaques in their coronary arteries. Now, these plaques don't necessarily have to be right at the aorta, but if there's a plaque anywhere, it's going to increase pressure and increase the workload of the heart to get blood to flow around those blockages. As clients get older, vascular tone is diminished and our vessel walls just really aren't as strong as they used to be, also putting us at risk for a AAA. Finally, clients of the male sex are at a higher risk for AAA. Most clients who have a AAA are actually asymptomatic and don't know they have it. It's generally diagnosed when we're looking for something else with ultrasound or imaging. When clients do have a AAA, they're going to have a pulsatile abdominal mass. So if you palpate over the abdomen where the aneurysm is, you're going to feel the beating of the heart and the pulsing of the artery. Unfortunately, the first time clients present with symptoms may be when the aneurysm has already ruptured. Clients may present with intense abdominal, back, or flank pain as blood begins to fill the abdomen, and they're going to have a decrease in blood pressure and an increase in heart rate. The blood pressure is decreasing because there's not enough circulating blood to go around, and the heart rate's increasing in an effort to increase the amount of blood being circulated. These clients are having early signs of hypovolemic shock, and we need to intervene quickly. If a client presents with a ruptured AAA, first and foremost, we need to transfuse lots and lots of blood. They're going to have a lot of blood, but it's all just going to be pooling in their abdomen. So we need to increase the amount of blood circulating in the body. We can give things like packed RBCs or fresh frozen plasma, and we also can give IV fluid boluses to temporarily increase the circulating volume until we can get more blood in their body. These clients need immediate surgery, and it's oftentimes going to be an open surgery. We're going to open the abdomen to get to the aorta and perform a resection. If you look at the graphic, you can see the abdomen is open and a graft is sutured in at the aneurysm site. The aneurysm is then sewn over the graft so blood flow can be restored. After surgery, we also need to monitor urine output every hour in these clients. Because of the rupture, they've had a disruption in their circulating volume and a disruption in their perfusion to organs like the brain and the kidneys. If the kidneys haven't been perfused properly for a while, they're not going to properly make urine. These clients may also be hypovolemic or not have enough volume circulating, so we need to increase it with more blood or more IV fluid. Lastly, as clients are recovering, we need to teach them to limit how much they are lifting. Lifting heavy weights can cause re-rupture of the aorta and put them right back where they started. So clients who have a ruptured aneurysm are going to almost always require an open correction of the aneurysm. But if a client has a stable aneurysm that's growing and at risk for rupture, we can also complete an endovascular or closed repair of the aneurysm to prevent it from rupturing. With endovascular repair, a catheter is placed up the femoral artery and into the aneurysm space. A stent is deployed and left in place while the catheter is removed. The stent helps to restore blood flow and prevent aneurysm rupture. For clients who don't need immediate surgery, we want to help them understand their risk factors and how to modify them. The biggest is to stop smoking if they are a smoker. We need to control their blood pressure. So quitting smoking is going to help control blood pressure. Changes in diet and increasing exercise can also help control blood pressure. If clients are prescribed medication for their blood pressure, we need to make sure they are taking it as prescribed and logging their blood pressure so the healthcare provider can determine if control is adequate. Clients with known aneurysms need to follow up regularly with their healthcare provider to monitor the size of the aneurysm. If an aneurysm grows too quickly or becomes too large, it's going to be at risk for rupture. So clients will often have imaging every couple months or every year to monitor the size and make sure the aneurysm is still manageable. Finally, clients with known aneurysms need to understand the signs of rupture and to report them to the healthcare provider. This includes things such as sudden and severe back pain or abdominal pain.
This topic is abdominal hernia. An abdominal hernia refers to the protrusion of abdominal contents or bowels through an opening in the abdominal wall. Now, there are 3 different types of abdominal hernias. The first is an umbilical hernia, which occurs in the region of the umbilicus or navel. The second is an incisional hernia, which can occur following an abdominal surgery. And the third is an inguinal hernia, which is a hernia that occurs in the region of the groin. On this slide, we see an image that has a great depiction of an umbilical hernia, which occurs at the navel, otherwise known as the belly button. This type of hernia is a midline protrusion that is often reducible. This means that if we were to apply pressure to that protrusion, it would recede back into the abdominal cavity. This type of hernia is common in children and will occur following an incomplete closure of the umbilical opening following birth. In most cases, umbilical hernia will resolve spontaneously in children. For adults, umbilical hernia can occur due to weakness of the rectus muscle, which is more common in individuals that may be obese. Additionally, increased intra-abdominal pressure, such as from abdominal ascites or the presence of certain tumors, can also contribute to the development of umbilical hernia. An incisional hernia is exactly what it sounds like. It is a hernia that occurs at prior sites of surgical incision, and we can see an excellent depiction of an incisional hernia in the image on this slide. Following surgery, incisional hernia is more likely to occur in individuals who are obese, have had multiple surgeries which can lead to a thinning or weakening of the fascia and muscle tissue in the abdomen. This includes those who have poor nutritional intake of carbohydrates and proteins necessary for wound healing, or those who have had a surgical site infection postoperatively. An inguinal hernia occurs from a weakening of the lower abdominal muscles and fascia, and this is more likely to occur in males than females. When the lower abdominal tissues allow for protrusion of the bowel can descend all the way down to the scrotum, as we can see on the image here in this slide. Just like the other 2 types of abdominal hernias, risk factors for inguinal hernias are associated with an increase in intra-abdominal pressure. This includes things like obesity, chronic constipation, or the presence of a chronic cough. Signs and symptoms of inguinal hernia include a palpable bulge in the groin. Now, this bulge will typically get larger when the client stands up and is often reducible when the client is lying down or through physical manipulation by the healthcare provider. Additionally, the hernia may occur unilaterally or bilaterally. And if we look here at the image on this slide, we see a great depiction of a bilateral inguinal hernia. The client may have dull, lower abdominal.
The topic is acute glomerulonephritis. Let's review the normal nephron. The primary job of the nephron is to remove waste products in both the processing and the filtering function. Let's review the glomerulus. The glomerulus is located at the beginning of every nephron, and remember, we have over 1 million nephrons per kidney. The glomerulus is the main filtering agent of the kidney. You can see by our illustration that the glomerulus is made up of loops of capillaries. This requires adequate blood flow to bring those waste products into the kidney so that we can determine what is essential, what is waste product, and then move it through the system. We can calculate the rate of filtration. How quickly are these products moving through the glomerulus? This is known as the estimated glomerular filtration rate. This is a serum blood test. Now let's focus on what actually is acute glomerulonephritis. When we think of glomerulonephritis, think of the end part of that word, itis. That means inflammation. There is a direct inflammation and destruction of the glomerulus. Those loops of capillaries become scarred or sclerosed. As a result of this, we begin to lose kidney function. The more glomeruli that are damaged, the worse the kidney function is. In most cases, acute glomerulonephritis is caused by an immune-mediated condition. Our most common causes of acute glomerulonephritis consist of strep infections, primarily of the throat, and also clients who have systemic lupus. With strep infections being the most common cause of glomerulonephritis, let's focus on that. Strep infections are most commonly associated with throat infections or tonsillitis. We may also see it with skin infections. Strep infections are most common in our school-aged children. So one may wonder, how in the world does a strep infection that's in the throat find its way all the way to the kidney and cause this kind of damage? Let's take a look at that more in depth. When we have an infection, such as a strep infection, this then creates an antigen-antibody complex. Now, what happens in acute glomerulonephritis is this complex now travels to the kidney specifically, and it lodges itself in the glomerulus. And by lodging itself in the glomerulus, it is now embedding itself in those capillary walls and membranes. This then leads to damage and increased permeability of that basement membrane. Ultimately, your GFR will begin to decrease, your kidney function will decline, and the client will begin to retain fluid as well as electrolytes and waste products. This illustration demonstrates to you what we just summarized on the previous slide. When looking at this illustration, the green objects on the picture depict for us what that antigen-antibody complex looks like. As you can see in this particular picture, this is one glomerulus. Now imagine this is affecting hundreds, if not thousands, of glomeruli within the kidney. Once that antigen-antibody complex connects itself to that basement membrane of the capillary walls, it causes damage. This will now cause leaking and increased permeability. We don't want that in our kidneys because, as you can see in our picture, we now have red blood cells and protein leaking through that filtering process, which now will end up in the urine. That's not a normal place for red blood cells or protein to be. When we think about clinical features or what will the nurse assess for, we will see signs of oliguria. Remember, this means low urine output. There will be changes in the urine consistency and color. It will now become rust-colored or dark, meaning the presence of red blood cells are evident. We may also see signs of proteinuria. In addition, the nurse may be assessing the client for signs of edema, in particular periorbital edema. Why periorbital? That means around the eyes. Think about the skin that's around your eyes. It's very saggy and baggy, and it also is thin. This is a great place for fluid to migrate. In addition to that periorbital edema, there may be evidence of peripheral edema, meaning the nurse may see anywhere from +1 to +3 types of generalized edema. Because of the fluid retention, the nurse may also see signs of increasing blood pressure, evidence of hypertension. We will also see weight gain associated with that fluid retention. And overall, the client just doesn't feel well. They're going to have flu-like symptoms. What will our diagnostics provide for us? A basic urinalysis will tell us a lot. There'll be presence of red blood cells as well as presence of protein. We're going to see our standard renal tests, such as BUN and creatinine, will be grossly elevated. We will see evidence of a recent streptococcal infection, either a positive blood antigen test or a positive throat culture. In regards to the medical management, there really is no specific treatment for post-streptococcal glomerulonephritis. Most children will recover spontaneously and uneventfully. However, there are some complications that the nurse must be monitoring for. one being hypertensive encephalopathy. Again, remember with that fluid retention, one of the places it could go is into the brain. We may see signs of increased intracranial pressure due to that hypertensive state. We could see signs of headache, nausea, vomiting, and even seizures. If there is a change in level of consciousness, we should alert the healthcare provider immediately. We may also be monitoring for acute kidney injury. Remember from our previous slides, the picture illustrating the damage done to the glomerular basement wall. This could lead to acute kidney injury, so be monitoring closely for that. We want to be monitoring for fluid overload. Examples of this may be systemically. When we're listening to lung sounds, the nurse may be hearing the presence of rales. In addition, we may be monitoring for edema as well as weight gain. Evidence of pulmonary edema would be present by a productive, frothy cough. Most clients require just supportive care. We may be implementing antihypertensive agents, especially if that client is demonstrating hypertension. If the client's kidneys are still working effectively, we will implement the use of diuretics. This will allow us to assist in the process of eliminating that extra fluid that is in the body. For some cases, as it is rare, temporary dialysis may be required. This would be in the form of hemodialysis. When the kidneys are not functioning properly, as we've noted, there will be retention of fluid. There's also going to be retention of waste products and electrolytes. Sodium in particular will be retained. And remember, wherever sodium is present, water will follow. So we will implement a sodium-restricted diet for the client temporarily. We will also implement fluid restrictions, monitoring those vital signs for changes such as the increase in blood pressure, increase in heart rate. Vigilant intake and output documentation must be done. We need to know how much has gone in, how much is coming out. This is also in relationship to those daily weights. Using the same scale every day is important because some scales can differ. And as we've noted before, every ounce matters. Monitor for neurological changes that may be occurring due to fluid retention in the brain. So report any onset of headaches. Monitoring for seizures will also be indicated. And lastly, and very importantly, make sure that we are administering those antibiotics if indeed this is due to a strep infection. Any future strep infections must be treated accordingly because this could lead to further damage of that glomerular membrane wall.
This topic is acute kidney injury, also known as AKI. For us to better understand AKI, let's first review the renal system and how it works. Everything in the renal system starts with the kidneys, which help to filter waste from the blood in our body. As the kidneys begin to filter this waste, they can also choose to reabsorb water and electrolytes or eliminate them along with the waste in the form of urine. When waste is filtered through the nephrons, it deposits in the renal calyces and eventually collects within the renal pelvis. Urine then travels from each kidney down both lengths of each ureter and eventually collects within the bladder. In the bladder, the urine is stored until we are ready to eliminate it via the process of urination, where it leaves the urethra. Most of the time, this process occurs unimpeded. However, several complications can occur that lead to the development of acute kidney injury. These complications are classified as prerenal, meaning happening before the kidney or inside some other part of the body, intrarenal, meaning something is occurring within the kidney itself, or postrenal, meaning that something is affecting some other part of the renal system that is not the kidneys. We'll take a closer look at these causes of AKI on further slides. AKI is an abrupt decline in kidney function that results in the impairment of waste elimination and contributes to the development of imbalances in fluids and electrolytes within the body. Like I mentioned earlier, AKI has prerenal, intrarenal, or postrenal causes. Prerenal causes are factors that affect kidney function outside of the renal system and are usually a result of a decrease in blood flow to the kidneys. This image here depicts a nephron, and we can see blood vessels connected to the glomerulus. If blood flow decreases to the glomerulus or other parts of the nephron, this can lead to tissue impairment and evolve into kidney dysfunction. Intrarenal causes are factors associated with direct injury to the kidney tissue itself. The kidney is made of nephrons, which consist of glomeruli and tubules. So, if we have conditions like glomerulonephritis, which is inflammation of the glomeruli, or tubular necrosis, which can occur from ingestion of certain chemicals, drugs, or tissue ischemia to the tubule itself, can lead to the development of kidney tissue damage and kidney dysfunction. Postrenal causes are factors that cause a backflow of urine into the kidneys and cause increased pressure within the renal pelvis and renal calyces. This increase in pressure within the kidneys will cause a decrease in blood flow and ultimately result in kidney dysfunction. Two common causes of postrenal AKI are benign prostatic hyperplasia and ureteral stone obstruction. Now, benign prostatic hyperplasia, or BPH, is an obstruction that occurs within the urethra, leading to buildup of urine into the bladder and can eventually back up through the ureters into both kidneys. While a ureteral stone is only going to affect one ureter and one kidney, however, both instances can lead to acute kidney injury. Clinical features of AKI occur in 3 stages. The first stage is the initial stage, where the client may have some subtle symptoms, but should still have some urine elimination. One way we can monitor for whether or not the client is developing AKI is to see if they have a slight increase in BUN and creatinine levels. BUN and creatinine are waste products that are eliminated by the kidneys and can be correlated and associated with overall kidney function. The second phase is the oliguric, meaning low urine output, or anuric, meaning no urine output. And this phase is characterized by urine output that's less than 500 milliliters in a 24-hour period of time, a progressive increase in BUN and creatinine levels, an increase in serum urea levels, which is a waste product, again, that's typically eliminated by the kidneys. This results in uremia, which can cause symptoms of anorexia, nausea, vomiting, and pruritus. Metabolic acidosis can occur due to the kidney's inability to filter waste products and eliminate excess hydrogen ions. This buildup of hydrogen ions will essentially decrease our serum bicarbonate levels, or HCO3. One way the client may try to get rid of excess acid within the body is by breathing it out in the form of carbon dioxide. This may present in the form of Kussmaul respirations, which are rapid and deep respirations. Due to decreased kidney function and elimination of urine, the client may develop hypervolemia. Essentially, they have an abnormal increase in circulating fluid volume, which can lead to the development of hypertension and eventually can cause things like peripheral edema or pulmonary edema due to leaking of fluid from the blood vessels. And because electrolyte elimination is impaired with this client, we can expect an increase in overall electrolyte levels and can expect to see things like hyperkalemia and hyperphosphatemia. Following the second phase, we enter the third and last phase, which is the diuretic phase. In this phase, the kidney's glomerular function has slowly returned. However, because the kidney's tubules are affected and are unable to concentrate waste appropriately, this results in heavy diuresis and fluid volume loss. This phase is characterized by a slow increase in urine output, followed by heavy diuresis of up to 4 to 5 liters per day. This can result in fluid and electrolyte losses and ultimately result in hypovolemia and hypokalemia. We should see BUN and creatinine levels start to decrease, and kidney function returns to normal or near normal gradually. Interventions include correcting the underlying cause, whether that's a pre-renal, intrarenal, or post-renal cause. If the client has a kidney infection, we want to administer antibiotics. Or if the client has an obstruction, we want to reduce or eliminate that obstruction to improve urine flow, which will essentially help when it comes to increasing blood flow back to the kidneys. Use of nephrotoxic medications should be avoided, and if the client is taking nonsteroidal anti-inflammatory drugs or aminoglycoside antibiotics, such as gentamicin, these should be discontinued. Because many medications are eliminated by the kidneys, we may need to consider medication dosage adjustments, especially in the case of decreased elimination when it comes to the oliguric or anuric phase, or increased elimination when it comes to the diuretic phase. Even if the medication is not nephrotoxic, we may need to adjust the medication dosage to avoid accumulation. On a similar note, we will need to monitor for strict intake and output, as well as any fluid or electrolyte imbalances that may occur. This is where it becomes very important to know whether the client is experiencing symptoms associated with the oliguric or anuric phase versus the diuretic phase. In the oliguric anuric phase, the client will be retaining fluids and electrolytes, meaning these will be elevated and the client is more likely to have things like pulmonary edema and hypertension, as well as hyperkalemia and hyperphosphatemia. In contrast, if the client is in the diuretic phase, we're losing fluids and electrolytes, so we should monitor for low blood pressures as well as decreases in electrolyte levels like hypokalemia. For the oliguric anuric phase, we should monitor lung sounds for the presence of crackles and the blood pressure for hypertension. Additionally, due to the buildup of potassium, we want to administer a potassium-restricted diet to avoid any further increases in serum potassium levels. Daily weights and renal function should be monitored frequently to assess for any weight gain or loss, as well as an improvement or decline in kidney function. And lastly, if kidney function has become significantly impaired, the client may need temporary or permanent hemodialysis to remove excess fluids and monitor electrolyte levels.
This topic is acute myelogenous leukemia. So let's first discuss what leukemia is. Leukemia is a malignant or cancerous disorder of the bone marrow. The bone marrow is where stem cells are produced. These stem cells can mature into red blood cells, white blood cells, or platelets. Now, when it comes to acute myelogenous leukemia, or AML, we have an issue with the myeloid cells. Myeloid cells are a form of white blood cell, and immature white blood cells are referred to as blasts. These immature white blood cells, or blast cells, are non-functional. So when it comes to acute myelogenous leukemia, or AML, these myeloblast cells are overproduced and not regulated. This creates a decrease in the fully matured and functioning white blood cells in the bone marrow. These myeloblasts will fight for nutrients against the healthy cells. They'll take up a lot of those nutrients. This will create an issue of decrease in the mature functional white blood cells and an overproduction in these non-functional baby white blood cells. Now we discussed what all the bone marrow does and produces. When we have this overproduction of one type of immature cell, all the rest of the matured healthy cells will be decreased in number, and this is referred to as pancytopenia. So let's discuss what these clients are going to show in their clinical features. With pancytopenia, again, we're referring to decreased red blood cells, white blood cells, and platelets. These are in reference to the fully functioning cells. With the decreased functional red blood cells, it's also called anemia. So we'll see pallor and fatigue. With thrombocytopenia, also known as decreased platelets, we're going to see increased bruising, increased bleeding. This is even with small, insignificant injuries. When we're brushing our teeth, it can cause small breaks in the gums and they'll start to bleed. Petechiae, those are just small dots on the skin that can be bruises due to ruptured capillaries. Now remember, this is not a decrease in the production of platelets, this is a decrease in the functioning platelets. And the most important issue that we have here with AML is a decrease in the matured functional white blood cells, also known as neutropenia. When we have decrease in white blood cells, our immune system is compromised and will be at increased risk for infection. Now, these generalized symptoms that we'll see in our clients with AML are weight loss and bone pain. Remember, these blasts, immature cells, are taking up all the nutrients from the healthy cells, so we're going to lose weight. There's overcrowding of these blast cells in the bone marrow, so it causes increased pressure in there due to the volume of cells and then causes bone pain. So how do we best care for and treat these clients? We first want to make sure that AML is the diagnosis and this is a cancerous malignant disorder. So the way to diagnose that is with a bone marrow biopsy and aspiration. As you can see in this diagram, the healthcare provider will place a large bore needle into the iliac crest, into the bone marrow, and will aspirate the bone marrow contents. It will then be tested and we'll be able to see this overproliferation of those blast cells. Preparing the client for chemotherapy is also important. Radiation may also be a part of the plan, and this is to decrease that overproduction of those immature cells. These clients have a decrease in all of their mature cells, so we want to replace whichever cells are decreased. So if they're low in platelets, we'll give them platelets. If they're anemic, we'll give them red blood cells. We want to make sure that they are leukoreduced and irradiated. What that means is we want to decrease the chance of a reaction, kind of like a graft versus host reaction. So when we leukoreduce them and irradiate them, that decreases that risk of that reaction. Now, there is a life-threatening issue that can occur from AML called neutropenia. This is a severe decrease in those healthy white blood cells. We determine this level by an absolute neutrophil count. So this is going to tell us exactly the amount of healthy white blood cells we have. When this level is below 500, that's life-threatening and we need to address it immediately. So our number one priority with these clients is to decrease the risk of infection, and we do that by implementing neutropenic precautions. Neutropenic precautions means that we'll always wear a gown, gloves, and a mask when caring for these clients. Live vaccines can expose them to a small dose of a virus. We need to avoid these vaccines as they are immunocompromised, and even this small dose of a live virus could cause severe complications. Disinfecting all equipment is pertinent to decreasing the spread of bacteria and viruses. Educating our clients on how they can decrease their exposure at home is also important. We want to avoid large crowds, as many people can carry bacteria and viruses without knowing or showing symptoms. Good hand hygiene is always our number one priority. Avoiding raw fruits and vegetables is something we don't really think about, but they can carry natural bacteria that we want to make sure we're washing off before our clients consume it. Flowers can also carry different types of bacteria, so we want to avoid any fresh flowers being in contact with these clients. Avoiding anyone with an active infection or active symptoms such as cough, fever, or congestion. Even a common cold can cause extreme complications in our clients with AML. These clients can experience mucositis, which is known as lesions or ulcers in the mouth, which can be very sensitive and causes a break in those mucous membranes. This is due to the chemotherapy. Our mucous membranes are all the way from our mouth, through our intestine, and down to our anus. So we want to make sure we're taking care of the top and the bottom. With this break in those mucous membranes, we want to make sure we're using a soft bristled toothbrush so we don't create any further breaks in that mucous membrane in the mouth. We also want to make sure we're not using any enemas or digital thermometers to decrease a possible break in the mucosa of the anus. Medicated mouth rinses will also be effective in cleaning out the mouth and promoting good oral hygiene to decrease infection.
This topic is Addison disease. Addison disease is a disorder of the adrenal cortex which leads to low levels or insufficient levels of corticosteroids that are circulating throughout the body. Before we talk about Addison disease in depth, let's look at a normal stress response within the body. Let's first talk about how corticosteroids are naturally released into the bloodstream. We're going to look at two organs specifically, being the pituitary gland and the adrenal gland. Our body is naturally going to need and release corticosteroids when there is a stress response. The pituitary gland is going to release adrenocorticotropic hormone, or ACTH. This hormone is going to make its way to the adrenal gland, which is going to result in the release of a number of corticosteroids. One of the most important corticosteroids that's released is cortisol, and cortisol we can think of as a stress hormone. As cortisol levels build up within the blood, this is going to result in a negative feedback loop. The more cortisol we have, the less release of adrenocorticotropic hormone that we're going to have from the pituitary gland. As the stress response begins to wear off within our bodies, this means that decreased level of adrenocorticotropic hormone is going to lead to decreased levels of cortisol, which will then become normal. When the adrenal cortex has been affected, this can lead to a depletion of very important corticosteroids within our body, such as cortisol, aldosterone, and androgens, which are important in growth and sexual development. One of the main reasons that we have this hypofunction of the adrenal gland is from an autoimmune disorder or process that leads to destruction of the adrenal gland tissue. This is a chronic condition and something that happens over time, which will eventually lead to an inability by the adrenal gland to release enough corticosteroids in response to a stressful situation. Clinical features of Addison disease are associated with an insufficient amount of these corticosteroids within the body. While these features are mostly going to be associated with decreased levels of cortisol, decreased levels of aldosterone, which is important for sodium and water reabsorption, as well as decreased levels of these androgens can also contribute to these clinical features. Again, we think of cortisol as a stress hormone specifically. When we don't have that stress hormone and it's not regulating certain processes within our body, this can lead to a low mood as well as depression. Cortisol enhances the effects of catecholamines like epinephrine and norepinephrine. Now, these catecholamines can lead to vasoconstriction. So when we have a lack of cortisol within the body, this can help contribute to hypotension, especially if we have a decrease in the amount of circulating aldosterone, which is important for water reabsorption, and we can have low cardiac output. With a lack of cortisol within the body, we have a lack of that negative feedback loop that's going to limit the amount of adrenocorticotropic hormone released by the pituitary gland. So that adrenocorticotropic hormone can continuously be released, which is going to affect another hormone, the melanocyte-stimulating hormone. This can lead to a hyperpigmentation of the skin, especially in areas that are sun exposed. A lack of androgens within the body can lead to decreased axillary and pubic hair, especially in females. Decreased levels of cortisol can affect metabolic changes within the body. Cortisol itself leads to insulin resistance and gluconeogenesis by the liver. So when we have a lack of cortisol, we have a lack of glucose that's being produced by the liver, as well as decreased insulin resistance, meaning insulin is going to take and sequester that blood glucose that's circulating throughout the body. This, coupled with a decreased appetite, can lead to hypoglycemia. As we lose sodium and water because of a lack of aldosterone, the client can develop salt cravings. Additionally, with a decreased appetite, clients can get fatigued very easily as well as develop muscle weakness. It's very important to note that clients with Addison disease can develop a life-threatening condition referred to as Addisonian crisis. Essentially what happens is the client is subjected to a level of stress that is too significant for the body to handle, and hormonal response cannot meet physiological demands. There's a number of risk factors that can lead to the development of Addisonian crisis, such as any increased stress or trauma. Infection or illness can precede Addisonian crisis, as well as abrupt discontinuation of certain medication, especially certain corticosteroid or glucocorticoid medications. When the body can't meet these physiological demands, this can lead to severe hypotension, tachycardia, and the development of shock. Treatment for Addisonian crisis involves intramuscular hydrocortisone use, as well as IV fluid resuscitation to keep that blood pressure from bottoming out. The adrenal tissue that's been lost that has led to Addison disease cannot be replaced. Therefore, clients with Addison disease are going to need hormone replacement that is lifelong. It's important to keep an eye on the blood pressures of these clients, as again, they can develop that hypotension. And we should teach the client about stress reduction techniques to avoid the development of that Addisonian crisis. The client should immediately report any signs of infection or fever, anything that could cause that increased level of stress within the body. And it's very important that they wear a medical alert bracelet. If that client were to be involved in any type of significant trauma, such as a car accident, it's very important that that intramuscular hydrocortisone is administered as soon as possible so the client's body will be able to respond to life-saving interventions. With that decreased appetite, clients should focus on maintaining a diet that's high in protein as well as high in carbohydrates to maintain their energy as well as maintain their muscle mass. And they should increase their fluid intake due to an increased risk of fluid loss from that decreased level of aldosterone within the body. Before we wrap up our presentation on Addison disease, let's draw a quick comparison between Addison disease and Cushing syndrome. We want to think of these disease processes as two sides of the same coin. Where Addison disease is a lack or insufficiency of circulating corticosteroids, Cushing disease is an abundance or excess of these corticosteroids over an extended period of time. There's a number of clinical features that are the opposite of each other. So with Addison disease, where we're at risk for that hypotension and low cardiac output, Cushing disease, we're at risk for hypertension as well as cardiac hypertrophy due to that hypertension. With Addison disease, we can have a decreased appetite and are at risk for hypoglycemia, whilst with Cushing disease, we have an increased appetite and are at risk for hyperglycemia. Increased levels of androgens with Cushing disease lead to the development of growth of facial hair in women, while again with Addison disease, we can have that loss of axillary and pubic hair. We'll discuss Cushing syndrome in a separate presentation.
This topic is age-related macular degeneration. Just as the name implies, age-related macular degeneration, or AMD, is a progressive age-related loss of vision. The macula, which is the central portion of the retina, deteriorates over time. Risk factors include tobacco use, hypertension, or a family history of AMD. Additionally, it's pretty nonspecific, But like I said, this condition is age-related, so as clients become older, their risk for it is going to simply increase. Now, it's important to note with AMD that there is not an increase in intraocular pressure like other eye conditions such as glaucoma. The problem with AMD is the vasculature. There are two major types of AMD. The first and more common of the two is dry. This is ischemia and atrophy of the macula from drusen buildup. Drusen are protein and lipid buildups in the eye. As you can see in the graphic here, the membrane begins to thicken, and as the membrane thickens, blood supply is decreased. Dry AMD can eventually progress to wet AMD, which is a more severe type. To compensate for decreased blood flow, new vessels begin to form in the eye. These vessels bleed and leak fluid into the eye, causing further macular degeneration. AMD can affect one or both eyes. It's important to note that it is a progressive vision loss rather than acute. Clients aren't going to wake up one morning suddenly unable to see. It's going to progress over time. Clients with AMD are going to have visual disturbances such as blurred vision, wavy vision, or scotomas, which are blind spots. One of the hallmark features of AMD is the loss of the central field of vision. The peripheral vision is going to be intact, but as you can see in the image here, the central vision is going to become dark and appear black. The healthcare provider can use ophthalmoscopy to visualize the structures of the retina and look at the macula. They can look for signs of degeneration, such as drusen, or new vessels, or even leaking vessels. Because AMD is progressive and chronic, we can't stop what's happening. Instead, we need to focus on slowing the deterioration and maximizing clients' independence. To help preserve vascular integrity in the eye, smoking should be discouraged. Regular physical activity should be encouraged to promote blood flow, especially to the eyes, and clients should maintain a healthy blood pressure as well as cholesterol levels. High cholesterol levels can contribute to drusen buildup, and increased blood pressure can cause additional hemorrhaging of blood vessels in the eye. Clients need to increase their intake of antioxidants. They may take supplements such as vitamin C or vitamin E, and they should increase their intake of dark leafy vegetables like kale and spinach. These clients are going to be slowly losing their central field of vision, which means their sense of independence is going to decrease. We want to help clients be as independent for as long as they can, so we want to assist them with their activities of daily living and making lifestyle changes. Clients should be encouraged to use public transportation instead of driving as vision worsens, and we may want to provide large print books to help them see better. If we're providing education on a medication or a new diagnosis, we want to make sure the print is readable for the client. Additionally, clients should have regular eye exams to check for worsening AMD and wear corrective lenses as prescribed. Like I said, we cannot stop the progression of AMD, but we can slow its progression. Angiogenesis inhibitors can be injected directly into the vitreous cavity, and these are going to help limit the growth of new blood vessels. Laser therapy can also be done to promote clotting of leaking blood vessels and to slow our central vision loss.
This topic is Alzheimer's disease. Alzheimer's disease is an irreversible and progressive form of dementia. It's important to note that the word dementia itself describes a number of conditions that result in loss of cognitive function that leads to memory impairment. Alzheimer's disease is caused by neurodegenerative changes within the brain, and these changes are brought on by an abnormal amount of protein buildup. There are two types of proteins that can cause these abnormal changes within the brain. The first is beta amyloid proteins. Now, these proteins, when they deposit within the brain tissue, normally they are eliminated by the immune response. Essentially, the body recognizes this abnormal deposit and will send white blood cells and macrophages to digest that protein and eliminate it from the tissue. However, when these proteins clump together, they form plaques. Most of the time, these plaques remain deposited within the tissue, and the inflammatory response that is generated to try and remove these plaques results in cell damage and neuronal death. The other type of protein that can lead to the development of Alzheimer's disease is the tau protein. Now, instead of depositing outside of the neuron cell like beta amyloid proteins, this protein will deposit inside the neuron itself. As these tau proteins accumulate within the neuron, it will disrupt normal neuronal function and also result in neuron death. It's important to remember that communication between the neurons is how the brain actually functions and works. When we have a loss of communication between these neurons, this is what leads to abnormal brain function. For example, let's say we have 3 neurons. If neuron 1 normally communicates to neuron 2, which communicates to neuron number 3, and suddenly we lose neuron number 2, it's going to be much harder for neuron 1 to communicate to neuron 3, or that communication may not happen at all. The development of Alzheimer's disease is likely due to a combination of genetic and environmental factors. So individuals with a family history or who are genetically predisposed to this type of condition, as well as individuals who are not keeping up with their chronic conditions or living what would be determined as an unhealthy lifestyle, are more likely to develop the disease. However, if an individual is generally eating healthy, is managing any chronic conditions like diabetes, meaning they're keeping their blood sugar in check, or hypertension, meaning they're keeping their blood pressure down, this is more likely to reduce the risk. The overall impacts of these neurodegenerative changes within the brain are a decrease in cognitive function, as well as changes within the client's language and reasoning skills. With Alzheimer's disease, changes within the brain develop over time. Therefore, the manifestations for this client can vary depending on whether the client is in early stages of Alzheimer's disease versus late stages of Alzheimer's disease. Early findings include a decline in short-term memory and social skills. So oftentimes you may be talking to this client about what they were eating for breakfast, and they may not be able to recall what they had. Clients may have visuospatial deficits. An example of this is if the client were to go to someplace familiar like the grocery store, and on their way home they realize that they have become lost. Language difficulties may occur, meaning that the client may forget words or have trouble remembering them. Beyond developing complications with short-term memory, other forms of cognitive impairment include an inability to focus on a task or an ability to learn a new skill. And because of this, clients can develop self-care deficits. For instance, they begin to have issues with personal grooming, and they may find it difficult to dress themselves. For instance, you may notice that they have difficulty when it comes to buttoning a shirt. As cognitive function declines over time, we may be able to see some behavioral changes develop in these clients. Late findings include neuropsychiatric symptoms such as hallucinations or delusions. Non-cognitive neurological deficits may result. These are things like changes in emotion, the client may be more depressed or anxious, or they may be more irritable or angry. Because of this impaired communication of neurons within the brain, the client can develop extrapyramidal symptoms, myoclonus, which is muscle twitching, and are at risk for the development of seizures. Over time, the brain cells are shrinking and losing function, so we often see that the clients may lose bladder or bowel function on top of everything else that they're experiencing. There is no specific diagnostic test when it comes to confirming whether or not an individual has Alzheimer's disease. Usually, the healthcare provider will choose to rule out other disease processes that cause memory loss issues in order to form the diagnosis of Alzheimer's disease. One diagnostic tool that can be used to visualize for changes brought on by Alzheimer's disease is the use of an MRI. As the brain tissue is scanned, the healthcare provider is going to look for any diffuse atrophy of the brain tissue. And other causes will be ruled out. So for things that cause a decreased metabolism or decreased cognitive function like hypothyroidism, B12 deficiency, and depression, the healthcare provider will make sure to screen the client for these before diagnosing them with Alzheimer's disease. When it comes to taking care of these clients, one of the first things that we want to do and continue throughout their care is to perform cognitive assessments. Now, we can use formal tools like the mini mental state examination or the Montreal Cognitive Assessment, both of which use a series of questions to determine the client's overall cognitive function. These examinations are examples of what you may need to use at the bedside or when caring for the client. Other ways that we can monitor cognitive function is by checking the client's level of orientation, attention to detail, and the ability to recall specific information. For instance, one of the most common assessments we do at the bedside is to check the client's level of orientation. We can ask questions to see if they're oriented to themselves or the situation, as well as if they're oriented to the place that they're in or what time it is. And an initial assessment of the client's cognitive function helps us to establish a baseline so that we know if they have further declines in cognitive function as they move forward. One of the primary medication types that these clients receive are going to be cholinesterase inhibitors. Now, cholinesterase is an enzyme that breaks down acetylcholine within the body. So if we give a cholinesterase inhibitor, this increases the amount of available acetylcholine. By increasing acetylcholine, which is a neurotransmitter, we are attempting to increase communication between the neurons within the brain. And these medications include donepezil and rivastigmine. Another type of medication that we might give would be an N-methyl-D aspartate or NMDA receptor antagonist, such as memantine. This medication is given along with cholinesterase inhibitors in order to help retain cognitive function. As the disease process worsens the client's cognitive abilities, it may be important to designate someone to administer the medication to the client or to request that medications be provided in a patch form. In this way, it's more likely for the client to adhere to the medication regimen, which will help to decrease the decline in function. Early on in the disease process, when the client still is oriented and is able to make decisions, it's important that the client anticipate any future issues that may arise due to their inability to make decisions. So resolving legal issues now will be important as the client becomes unable to make decisions for themselves. This includes the generation of a living will, assigning a medical power of attorney, and determining what to do at the client's end of life. Throughout the disease process, it's important that the client is provided with a structured and consistent daily routine. Any new information that the client has to process or any deviation from a structured plan can result in frustration for the client, which can lead to irritability and anger issues. Another way that we can promote the client's well-being is by establishing a normal daytime and nighttime cycle. Some ways we can do this is by decreasing stimulation, especially in the afternoons and evenings. So we want to avoid things like caffeine as well as watching TV at later hours. We want to increase the client's exposure to daytime light, so if we can get them outside safely, that's a great idea, or we can make sure that we open windows and allow natural sunlight to come in. Throughout the day, we want to make sure that we're reorienting the client so that they know what time it is and what day it is. And we want to help establish a normal sleep cycle for them so they're getting enough rest, which is going to help promote their overall well-being. There are a number of safety interventions that we should consider. For one, we can use a door sensor. By doing this, we know if a client is attempting to use a door, and we can escort them wherever they're trying to get to or bring them back to a safe environment. Clients with Alzheimer's disease can become restless and tend to wander, and when they begin to do so, we want to establish a safe place where they can do this. It's important that these clients wear a medical identification bracelet in case they do get lost, and we need to encourage elimination of certain household hazards. This can be things like gas appliances. Throw rugs become a tripping hazard for these clients. Toxic chemicals should be stored securely or thrown away. And the installation of grab bars can help these clients in the shower and the bathroom. Now, while we've talked a lot about caring for the client with Alzheimer's disease, it's important that we address the caregiver's burden. For family or friends who are caring for an individual with Alzheimer's disease, they can become very exhausted, especially over time. We may need to encourage them to use respite care or long-term care in order to get a break from caregiver responsibilities. Additionally, they can join support groups to help deal with some of the emotional toil. Regardless of the type of care that the client is actually receiving, it's important that the nurse screen and check for mistreatment or neglect by the caregiver. Neuropsychiatric symptoms with Alzheimer's disease can include hallucinations, delusions, and aggression. Now, it's very important that if a client is experiencing any of these, we do not want to negate their experience. We do, however, want to continually establish reality and reorient the client. This includes assuring the client that they are safe, using forms of distraction like the use of familiar music or photographs. We may need to give simple directions to the client so it's easier for them to follow what we're asking them to do. For communication purposes, we should stand near the client, make sure we're making eye contact with them, and we may need to use visual cues and gestures. And again, because significant cognitive function can develop, we do not want to challenge these clients' delusions, as they can become frustrated, irritable, and angry, and may lash out at staff.
This topic is amputation of a lower extremity. Amputation means removal of a limb or partial removal of a limb, surgically or due to trauma. There's a couple reasons why we surgically remove a limb or part of a limb. We remove a limb or part of a limb due to ischemia, necrosis, or gangrene. These are all normally caused by lack of perfusion to that extremity. No perfusion, no blood, no oxygen causes ischemia and necrosis. This ischemia and necrosis can be caused by a couple different things. Peripheral artery disease. You can see in this image exactly what happens when peripheral artery disease occurs. The plaque in the artery causes lack of perfusion to the lower extremity. That lack of perfusion will cause intermittent claudication, pain because there's no oxygen going to that area. Then you might see no hair in that area, and the skin may be cool and clammy, decreased peripheral pulses, and then you might see those areas of ulceration that turn into necrosis or gangrene. Another surgical indication could be thromboembolism. Again, something blocking that blood going to the extremity. Or frostbite-related gangrene. Again, that oxygen, that blood is not able to get to the end of the extremity. Another indication could be complications of diabetes mellitus. Some of those clients have neuropathies, so they could bump into something, get a wound on their leg, and we know those clients have difficulty with wound healing. Then, if their blood sugars are not within normal levels, they also are susceptible to infection. And once that infection starts, it's difficult to contain. Osteomyelitis, infection of a bone, cancers of the bone, osteosarcomas, and then traumas. It could be a trauma from a car accident or a lawnmower accident or injuries of war. Types of lower extremity amputation. When amputation is done in the operating room, the surgeon wants to preserve as much of the tissue as possible, but they also need to remove anything that is dead or infected so that the remainder of the limb can heal. You can see in this image the different levels of amputation. A traumatic amputation can happen anywhere in the lower extremity. Above the knee amputation is in the red highlighted area. Below knee amputation is in the purple highlighted area. And then there's the cyme amputation. That's in the gold highlighted area. Most of the foot is removed, but the ankle remains. Midfoot amputation or transmetatarsal, that's in that light blue, and then toe amputations in the green highlighted area. If you come upon a traumatic amputation, you of course want to first contact emergency personnel, and then you want to stop the bleeding. Sometimes you can get a tourniquet of some sort, a belt or a shirt wrapped around that extremity and pulled tight to decrease the bleeding in that limb. You'll want to apply direct pressure to that bleeding. Now, I know you want to peek to see if it's working, but don't do that. Once you are applying pressure, keep that pressure steady. Any movement of that pressure could recause the bleeding, or it could even tear the arteries and veins more. You'll want to make sure that the extremity is elevated above the level of the heart to allow gravity to help you to bring that blood back to the core. If an amputation occurs in the fingers, you'll want to take that finger that was amputated, put it in a watertight bag, and then place it in ice water. You don't want to place it directly in ice because that could cause damage and make the finger unable to be reattached. Complications of any amputation. The client may be preparing for a prosthetic, so any complication could cause a delay to this. Infection of the wound or the bone. Hemorrhage, which could lead to hypovolemic shock. This can happen during a traumatic amputation, in surgery during an amputation, or even during recovery. Contractures. We'll talk a little bit more about that later. And then post-amputation pain. The client can experience different types of pain. Acute stump pain or residual limb pain. The client just had surgery. We expect them to have some pain. Ischemic pain due to lack of oxygen perfusing and circulating because of peripheral artery disease. And then phantom limb pain. Let's talk a little bit about that right now. Phantom limb pain is normally seen in clients who have chronic pain prior to the amputation. The client will feel real pain or tingling in the part of the limb that was amputated. It is believed that this is due to confusion with the spinal cord and brain and the nerve endings of the limb that was removed, at the area of the nerve that was cut and then the nerve that remains. This normally starts within 1 week of the amputation, and clients will feel crushing or shooting or tingling or sharp or burning pain. They may even feel heaviness or coldness in that area that has been removed. For these clients, sometimes that phantom limb pain will eventually subside, but for other clients, it becomes chronic. Nursing interventions for phantom limb pain include validating the client's pain. This is very real for the client. We don't want to be dismissive to their pain. We can administer prescribed analgesics, and then we can encourage them to do mirror therapy. For some clients, mirror therapy will decrease that phantom limb pain. The mirror therapy is thought to provide visual information to the client's brain, and it replaces sensory feedback from the missing limb. Additional complications include the psychosocial implications of amputation. These clients will have a disturbed body image, they may have decreased self-care, and they may socially withdraw. We want to help these clients with coping mechanisms. We want to encourage them to touch and feel and talk about the amputation and their residual limb. We want to encourage them to care for that residual limb. We want to encourage them to resume their social activities. And we want to encourage lifestyle modifications so they can return to maximal independence. Postoperative care for the client with an above-the-knee amputation includes contracture prevention. A hip contracture could be a debilitating complication for this client. So we want to do a couple things to prevent it. We want to lie the client prone for approximately 30 minutes, 3 to 4 times a day. Imagine if my head is here and my legs are here, we want to prevent that hip contracture. So by lying the client prone, it allows that area to be stretched. Also, we want to avoid them being in any sort of position more than an hour that could encourage that contracture. That could be placing a pillow under the knee, there's a contracture, or them sitting in a chair for longer than an hour. Again, there's that contracture. So we want to make sure if they're in those positions, we definitely lie them prone, as long as they're able to sustain that position. To keep edema to a minimum for this client in the residual limb, we'll use a figure 8 compression bandage. You can see in the image here how that's done. It's wrapped around the residual limb and then around the next large joint, which in this case happens to be the hips or waist. By wrapping it around the hip and waist, it keeps the bandage in place. For a client with this figure 8 bandage in place, we want to check it daily to make sure that the skin underneath has no signs of redness or odor or irritation, which could indicate a complication. Nursing interventions for this client includes pain management. We want to make sure we're monitoring it and also addressing any sort of pain that they're having. We want to encourage upper extremity strengthening exercises. Sometimes these clients have a trapeze apparatus on their bed. They can lift themselves on that trapeze apparatus, or they could even push themselves up in bed with their arms. These are 2 exercises that can encourage upper extremity strength, which is important for when they start to do crutch walking or gait training. Whenever we do any sort of dressing change on the residual limb, we want to make sure we use sterile technique. Again, remember, we might have removed this extremity due to infection. We don't want to reintroduce any sort of infection into the residual limb. In the recovery phase for this client, we're going to want to make sure we have a surgical tourniquet available to us. If the client starts to bleed, we can place that tourniquet on the residual limb, inflate it, and then immediately notify the surgeon. We want to teach the client how to care for their residual limb. This is an important step of their rehabilitation. The client will want to wash the limb daily with mild soap and warm water, and then thoroughly dry it to prevent skin breakdown. While washing the residual limb daily, they can also inspect it daily. You want them to look for any areas of skin breakdown or irritation or any signs of infection. If they note any of those signs, we want to encourage them to notify their physician. We also want to encourage them to lie prone at home several times a day. Again, remember to prevent that hip contracture. Have them lie prone to stretch that area out. Then perform those range of motion exercises, not only in their legs, but also in their upper extremities to strengthen both areas. We want to teach them to avoid applying any irritant on that residual limb, like rubbing alcohol or lotions or powders. A general rule to follow is if the surgeon didn't give it to you or if it wasn't provided by the hospital, don't put it on there, because we don't want any sort of skin breakdown to happen. We will also teach them how to care for limb socks or wraps or any prosthetics they're given in the hospital. For the limb socks, we want them to wash it with a mild soap, thoroughly rinse it out, wring out any sort of extra dampness, and then let it lie flat to dry. And don't use it again until it's completely dry. Because again, if it's moist or damp and is put on that residual limb, it could cause skin breakdown. We also want to provide the client any sort of amputation resources or support groups that could be of help to them. Keep up the good work. You got this.
This lesson is on anaphylaxis. Let's talk about the pathophysiology of anaphylaxis, which is a life-threatening, immediate hypersensitivity reaction. And it's often going to occur from a repeat exposure to an allergen. Usually what happens is you get exposed to something you're sensitive to, and your body ends up making antibodies, which is an IgE-mediated response. So your body ends up attacking itself. This is an activation of eosinophils, mast cells, basophils, all kinds of cytokines that are released. When it happens, it's going to hit two major areas. It's going to hit your vessels, causing vasodilation and increase systemic capillary permeability. What does that mean? Think of a leaky hose. If you try to water your garden through your hose and you have holes in it, you don't have any pressure in there, you don't have any fluid. The second thing it's going to do is cause laryngospasm or bronchospasm in your upper airways. Common allergens. What kind of food are we going to see that causes this response? We can see peanuts, we can see shellfish. Food additives will also do this to our patients, so red dyes. Bee stings is a really big one, high yield on your NCLEX. Biologic materials can do this, whether it's vaccinations or even antibody therapy. Rubber latex and blood transfusions are going to be the two major things that you're going to see on your NCLEX when it comes to anaphylaxis. Clinical features. What does my patient look like in anaphylaxis? You're going to see a rash. Usually this is going to be warm and it's going to be wet because we have that leaking hose. Our patient is losing blood and it is going to the peripheral. Swollen lips, tongue. With respiratory, they're going to be short of breath, right? They're having laryngospasms. They're having bronchospasms. You might hear stridor, so you might hear your upper airway narrowing. Versus wheezing, you're going to hear that lower airway narrowing. They have a leaky hose, so you're thinking arrhythmias and even syncope because they're not perfusing to their brain. You can also see all kinds of GI upset with anaphylaxis. What are my nursing interventions for a patient with anaphylaxis? Well, I need to immediately stop that blood transfusion if that's in the question stem. I'm going to activate my emergency response team. They're going to come and they're going to bring me epinephrine. And I'm going to give that epinephrine IM in that outer thigh, and I'm going to do that every 5 to 15 minutes until my client responds, until I see an improvement. Then we're going to place our client in the recumbent position, which means head back to get that perfusion back to the heart since I have a leaky hose. We're going to always think about the ABCs, administer oxygen, and definitely fluids because they're hypovolemic. Make sure that you have intubation equipment available because we did talk about laryngospasm and bronchospasm. Some other medications that we can think about for a patient with anaphylaxis are going to be albuterol, corticosteroids, or antihistamines. because remember, we have to open that airway that's closing and spasming. Make sure to initiate cardiac monitoring continuously at the bedside. Keep your client NPO, especially until symptoms resolve, because we want to make sure they don't aspirate with those bronchospasms. We also need to encourage our client to use an epinephrine auto-injector for emergency use, and we have to teach them how to use it correctly because eventually they're going to go home. So they need to know the signs and symptoms of anaphylaxis and the importance of contacting 911. When you're using an auto-injector, it is an emergency treatment, and we're going to administer it at 90 degrees firmly in our dominant hand. We need to remove that cap, place it on the outer thigh, and we're going to hold and make sure we're holding it for 10 seconds. Client education is going to be that each pen has one use, it's disposable, and we can also administer it through clothing. Make sure the patient is storing it at room temperature. Remember that the patient will have to call 911 after use for EMS services. Great job, you guys.
This topic is angina. Angina is simply a chest pain that's in response to myocardial ischemia or vasospasm. And there's three major types. The first is chronic or stable, the second is unstable, and the third is variant or vasospastic. First, let's start with chronic or stable angina. Chronic angina occurs due to a fixed partial obstruction of the coronary arteries. Symptoms result when myocardial oxygen demand exceeds supply, and this is also called exertional angina. This is going to occur with exertion, such as with stress or during emotional upset. Clients will feel chest pain, nausea, and dyspnea, but the key with chronic stable angina is that it's going to be relieved with rest or nitroglycerin. It's also important to associate chronic angina with stable and predictable. Chronic angina is going to have a predictable pattern of onset, duration, severity, and relieving factors. Clients are typically going to know what's going to cause their angina as well as what's going to improve the angina. Chronic angina also usually only lasts up to 5 minutes. Because clients with chronic angina are stable, we're going to treat them as outpatient. Our goal is to decrease oxygen demand and/or increase oxygen supply as needed. Preventatively, we can administer beta blockers, calcium channel blockers, and long-acting nitrates. All of these are going to reduce the stress on the heart and vasodilate the coronary arteries so blood can pass through more easily. When clients experience acute pain, we can administer short-acting nitroglycerin. Like I said, nitroglycerin is a vasodilator, so we're going to open up the arteries, reduce the amount of pressure, and allow the blood to slide through past blockages. It's also important for clients with chronic angina to treat the underlying atherosclerosis. So we want to administer antiplatelet agents such as aspirin or clopidogrel to prevent the platelets from clotting together. And we want to administer statin therapy to help reduce cholesterol levels. If we can reduce cholesterol levels, we can reduce circulating lipids in the blood and help reduce plaque formation. If atherosclerotic plaques continue to grow and the vessels continue to become more occluded, stable angina can progress to unstable angina or even myocardial infarction or MI. As coronary plaques grow, they have an increased risk of rupturing. When these rupture fully or partially, we have unstable angina. This is also known as pre-infarction angina. Unlike stable or chronic angina, unstable angina occurs unpredictably. Clients may not experience the same symptoms with the same exertion. Sometimes more exertion could result in worse symptoms, and sometimes more exertion may not result in any symptoms. As unstable angina progresses, it's going to occur more frequently, it's going to last longer, and it's going to become more severe of pain. And these clients are going to experience pain at rest or with even minimal exertion oftentimes. Sometimes the pain is not relieved by nitroglycerin, and this can often last greater than 10 minutes. The goal for clients experiencing unstable angina is to increase perfusion. We're going to position the client in an upright position as well as provide supplemental oxygen. Doing these things is going to decrease the peripheral vascular resistance and thereby decrease the workload of the heart. If the client's heart isn't working as hard to pump the blood pressure is going to go down and the force pressing against plaques is going to decrease. It's also important to assess the vital signs as well as the heart and lung sounds of clients with unstable angina. Clients are often hypertensive and can even get to a hypertensive crisis because there is so much pressure being put against the plaques. If there's an increase in that pressure, or if the pressure stays at an increased level, that plaque is at risk for further rupture and can cause a myocardial infarction. We also need to obtain a 12-lead ECG for these clients. Sometimes we'll see ST segment changes, and these can indicate MI, whether the ST segment is depressed or elevated. We also need to obtain cardiac biomarkers such as troponin on these clients. Now, because troponin is made in response to infarction, it's not going to be an immediate result. Oftentimes, we need to redraw the labs a couple times for these clients over a period of hours to actually see an increase in the biomarkers. So clients having unstable angina may need to be hospitalized overnight or for a day as an observation status to make sure we rule out myocardial infarction. If clients are experiencing pain that requires medication, we can administer nitroglycerin as well as IV opioid analgesics such as morphine. Morphine is going to decrease the preload and again decrease the work on the heart. It's also just going to reduce pain in general. Finally, if we have evidence of myocardial tissue damage such as ECG changes or an increase in serum troponin, coronary angiography is warranted. We need to perform a cath so the healthcare provider can go in and visualize areas of the heart for blockages as well as tissue necrosis. The final type of angina is variant or vasospastic angina, and this is caused by a coronary vasospasm. It often occurs at rest or during sleep and could also be triggered by smoking. Now, this form of angina may or may not be related to blockers. If you think about calcium, it's going to increase muscle contractility. If we're blocking some of that calcium, we're going to reduce it and reduce spasms. If clients are having pain from an acute spasm, we can administer sublingual nitroglycerin, or we can actually encourage them to complete light exercise. That movement and stimulation of the heart is going to increase the blood flow and open the coronary arteries back up and reduce spasm. This topic is aortic dissection. Aortic dissection is when a tear develops in the inner layer of the aorta, known as the intima. If you remember, the aorta is the largest artery in the body, and so there's a lot of blood surging through there. The blood is going to surge through this tear into the middle layer, or media, of the aorta. As the space between these two layers fills with blood, they begin to separate, or dissect. Additionally, a false lumen forms that allows blood to pass back and forth between the dissection and the aorta. There are two types of aortic dissection, type A and type B. We'll discuss more about those later, but know that type A involves the ascending aorta and type B is confined to the distal part of the aorta or into the subclavian artery. Type A is going to affect structures at the heart and above, whereas type B is going to affect structures below the heart, such as the bowels or the legs. One of the biggest risk factors for aortic dissection is hypertension. It is especially common in clients who have been taking medication for blood pressure control and suddenly stop taking for whatever reason. The blood pressure shoots up quickly and the dissection forms. Additionally, recreational drugs such as cocaine can cause a sudden and drastic increase in blood pressure that can lead to increased pressure on the aorta and cause a dissection. Finally, underlying aortopathy, such as in Marfan syndrome, causes the aorta to be at greater risk for tears or dissection. So let's talk about type A and type B dissections. With type A, clients are going to have a sudden onset anterior chest pain. They may describe it as a tearing pain or just the worst chest pain they've ever experienced. It could radiate up to the neck, jaw, or upper back. And like I said, this is going to be very sudden onset. It's not going to be gradual, it's going to happen pretty quickly. As blood begins to fill between the media and the intima, there's going to be less blood circulating around. So clients are going to become tachycardic. This, combined with pain, is going to make clients feel restless or anxious, and they're also going to be diaphoretic. Hypertension is also usually present. Like I said, hypertension can cause aortic dissection, but also once the dissection has occurred, the body is going to be trying to pump more and more blood to the extremities, even though it has less blood to circulate. This is going to raise our blood pressure. Now, if the subclavian artery is involved, there's going to be a big difference in the systolic blood pressure, which is the top number on your blood pressure reading, between arms. Imaging of the chest is going to show a widening aorta, and we'll talk a little more about these imaging techniques later. Finally, it's really important to understand that type A can be fatal and fatal quickly. Like I said, type A is going to involve higher structures, so it's going to more immediately affect blood flow to the heart, and it's also going to affect blood flow to the brain. In type B dissection, the lower part of the aorta and the lower part of the body is affected. So clients may have abdominal or back pain as blood begins to settle. One of the biggest complications of aortic dissection is life-threatening aortic. These clients are often going to have decreased urine output and an increased BUN and creatinine. If perfusion to the abdomen is altered, we can have ischemia of the intestines. If the perfusion to the spinal cord is altered, paralysis can occur. Limited blood flow to the extremities can result in cold arms and legs, and if severe enough, can eventually cause tissue necrosis. Finally, if we're not getting enough blood supplied to the coronary arteries, myocardial infarction, or MI, can occur. Like I said earlier, on imaging, we're going to see a widening of the aorta. This can be easily seen on a chest x-ray. Ideally, clients will have a CT scan to visualize the aorta. This will help the healthcare provider see where the false lumen is. Unfortunately, clients who are experiencing type A dissection may not have time for a CT scan and need to get to the OR quickly. For these clients, a transesophageal echocardiogram, or TEE, can be completed. In a TEE, an ultrasound probe is placed down the esophagus until it's at the level of the heart. Once the probe is at the level of the heart structures and the aorta can be visualized. This can also help us see where the false lumen is, as well as look at the lumen walls of the aorta in general. The priority intervention in aortic dissection is to reduce the heart rate and the blood pressure. We need to administer beta-adrenergic antagonists such as labetalol or esmolol. These drugs are going to lower the heart rate. Now, it's important that we lower the heart rate first before we lower the blood pressure. If we lower the blood pressure first, then try to lower the heart rate, we could end up with reflexive tachycardia. Reflexive tachycardia is only going to increase the pressure on the aorta and make the client's condition worse. We also want to keep clients in a semi-Fowler position or some other upright position to help reduce the workload on the heart. It's also important that we maintain a quiet environment with decreased stimuli. So we may want to limit the amount of visitors coming in, and we should cluster our nursing care. If we're doing things that are causing the client to become agitated or increase their blood pressure, we're going to make their condition worse. Tight blood pressure control is very important for these clients. We want to keep our systolic blood pressure between 100 and 120 millimeters of mercury. If our blood pressure is too low, we're not going to perfuse organs like the kidneys and brain, and if it's too high, we're going to increase our risk of aortic rupture. For many of these clients, an arterial catheter will be inserted for constant blood pressure monitoring. This is most commonly inserted into the radial artery and allows for continuous monitoring of blood pressure rather than using a cuff on the arm. Because these clients are at risk for aortic rupture and cardiac tamponade, we need to initiate continuous cardiac monitoring. Remember, these clients are going to be in a lot of pain, so opioid analgesics such as morphine are going to decrease pain. These are also going to decrease the workload of the heart. As I mentioned on a previous slide, there are a lot of potential complications, so we need to monitor for these complications. You may want to complete a stroke scale if you suspect that the client is showing signs of stroke, and we need to monitor our heart results in decreased white blood cells, red blood cells, and platelets. Most common cause is congenital and it's autoimmune. It also can be acquired, such as with viral infections or after exposure to toxic chemicals, especially in the case of chemotherapy. Things like chemotherapy can destroy the bone marrow and cause it to not produce the cells that it should. Let's look at the image to see the difference between normal bone marrow and bone marrow with aplastic anemia. In normal bone marrow, there are very small amounts of adipose tissue, and there are lots and lots of stem cells. These are going to eventually become our white blood cells, red blood cells, and platelets. But in aplastic anemia, you can see there is lots and lots of adipose tissue and a drastically reduced number of these stem cells. If there's not enough of these stem cells, they're just not going to create enough cells later on. Like I said, aplastic anemia is going to cause a decrease in our red blood cells, our white blood cells, and our platelets. This is going to manifest clinically, so let's look at some of these manifestations. Clients who have decreased red blood cells are going to have anemia. Remember, red blood cells are going to carry oxygen to the tissues and to the organs of the body. If there's not enough of them, enough oxygen's not going to get to the proper places. Clients are often very fatigued, have pallor or paleness, and exertional dyspnea. With decreased white blood cells, leukopenia is common. Clients are at a very high risk for infection, and if they develop an infection, even something small can become potentially deadly. Lastly, with decreased platelets, clients are experiencing thrombocytopenia. Their blood's not going to be able to clot like it should, and so they're going to have easy bruising or bleeding. They may have a small nick of a razor that causes extensive bleeding, or they may bump their arm just a little, but a giant bruise occurs. Petechiae is also very common. These are going to be pinpoint spots of blood under the skin. Aplastic anemia is a disorder of the bone marrow, and so a bone marrow biopsy is going to be how it's diagnosed. As you can see in the image, for a bone marrow biopsy, clients are going to be side-laying and in somewhat of a curled-up position. The biopsy needle is inserted into the iliac crest. It's going to go through the skin, the fat, and the muscle into the bone marrow. A sample is then taken and viewed under the microscope. Remember, these clients are going to have decreased red blood cells and platelets, so we can temporarily transfuse these to help supplement. But remember, the issue is with the client's bone marrow. They can't produce what they need, so this is only a short-term fix. Because the issue is with the bone marrow, the only way to truly correct aplastic anemia is to change the client's bone marrow. So this is going to occur through a bone marrow transplant. Now, bone marrow can be given just like any other blood transfusion, but the client's body is going to recognize it as foreign and try to destroy it. So, prior to the infusion, immunosuppressive agents like chemotherapy must be given. The client needs to have a wiped out immune system so it doesn't retaliate against the bone marrow being inserted. Once this bone marrow is infused, the client is going to hopefully accept it as their own and start regenerating it. Then they can produce the proper cells that they need for functioning. Clients with aplastic anemia are going to have reduced white blood cell counts anyway, but when we add chemotherapy for a bone marrow transplant, they're going to have even further reduced white blood cells. So, neutropenic precautions need to be implemented. First and foremost, we need to monitor the client for signs of infection, such as fever and increased fatigue. Additionally, these clients need to be in a private room. We want to minimize their risk of contracting an infection as much as possible. Along the same lines, we need to limit visitors, and visitors need to be screened prior to seeing the client. We need to make sure the visitor hasn't recently been in contact with someone who is sick. Finally, raw food and fresh flowers need to be avoided with these clients. They can introduce infection-causing pathogens to the client who doesn't have an immune system to fight it off. Remember also that these clients have a decreased platelet count, so we need to implement bleeding precautions. A soft bristle toothbrush should be used to minimize bleeding of the gums, and stool softeners should be administered as needed. If clients are straining too much, they can have rectal bleeding. And remember, these clients aren't clotting blood properly, and so it can be excessive. Finally, electric razors should replace manual razors. We want to reduce the risk of cuts and nicks because, again, this can cause substantial bleeding.
This topic is appendicitis. So let's discuss the fundamentals of appendicitis. Appendicitis is just inflammation of the appendix. The appendix is a small portion of the bowel that is not touching any part of the bowel in and of itself. It looks like a small tail coming off of the bowel. The inflammation of the appendix can be caused most commonly by an obstruction. And how do we get an obstruction in the appendix? Typically, it's caused by hardened fecal matter that can accumulate or an infection. Once we have an obstruction in the appendix, most fluids, mucus, and blood flow are unable to continue to flow through the appendix. With that obstruction, everything starts to back up behind it, including that mucus. This then creates increased pressure. The capillaries along the wall of the lumen feel that pressure and start to get compressed, and there's less room for blood flow. Once we have decreased blood flow through the lumen, the walls of the lumen can become necrotic or ischemic, which just means due to the lack of blood flow, there's no more oxygen reaching that lumen. Once these walls become ischemic or necrotic, we can have such buildup of pressure, the walls of the lumen can then burst, and that's what we know as a perforated or ruptured appendix. This can lead to peritonitis, which is known as an infection of the peritoneal cavity. Appendicitis is most common in school-aged children, but can occur at any age. So let's discuss the clinical features and what we might find on our assessment in a client with appendicitis. Just remember the acronym GRADE. These clients may present with abdominal guarding. Due to the amount of inflammation in the appendix, once it touches parts of the bowel, that's when the client starts to experience extreme pain. So standing in the stooped over posture can keep the appendix from feeling any pressure from other parts of the bowel and decreasing the pain level. The client can also experience rebound tenderness or localized right lower quadrant pain. As you can see in this diagram, the appendix is located in the right lower. We want to make sure we're checking bowel sounds frequently. Now I know we just addressed right lower quadrant abdominal pain and that localization of the abdominal pain. Clients can also experience a diffuse periumbilical pain in the beginning, so this is known as a referred pain. Clients may feel this generalized pain in their abdomen, but as the inflammation progresses, they will start to be able to localize the pain to that right lower quadrant. Clients will also experience elevated temperatures and elevated white blood cells, and this is due to the inflammation and infection. Nursing interventions that we want to implement for our clients with appendicitis include monitoring for any signs of perforation or rupture. So clients who are experiencing perforation or rupture of the appendix will have tachycardia or an increased heart rate, hypotension or low blood pressure, and they may also experience a very quick, brief relief in pain. That abdominal pain will come right back and it will be diffuse, as this is the appendix bursting and contents of the appendix filling into the peritoneal cavity. Diagnostic studies that we include for appendicitis are abdominal ultrasound or a CT scan. We typically see appendicitis in young children or possibly pregnant women, so we want to decrease the amount of radiation, and that would be the reason that ultrasound would be chosen over a CT scan. CT scan can have a little bit more detailed imaging and can be used for those clients who are okay with exposure to radiation. We want to ensure that we're auscultating bowel sounds frequently in order to monitor for an absence of bowel sounds. Clients with appendicitis may have an absence of bowel sounds because the bowel is trying to compensate for the amount of pain and inflammation, so it will slow its peristalsis or contraction and movement. We also want to make sure we're preparing our client for surgery, as this is an emergent proactive step in order to prevent any rupture of the appendix. We also want to make sure that we're preventing the client from eating or drinking, and this is for two reasons. If we're preparing the client for surgery, we want to decrease their risk of aspiration. We also want to keep the client from eating or drinking because if they do, this can actually cause increased pain and possibly increased nausea and vomiting. The bowel needs rest in order to heal due to the amount of inflammation in the appendix, so decreasing intake can be helpful. We also want to ensure that we're administering IV fluids to keep our clients hydrated, especially since they have decreased oral intake. Our clients are also typically nauseous and possibly actively vomiting, so we do want to administer any antiemetics, such as ondansetron. We want to treat the infection that's currently occurring in the appendix, so we do want to administer any prescribed antibiotics as well. Monitoring and treating pain for our clients is very important, and we can do this with pharmacological or non-pharmacological measures. Pharmacological interventions include pain medications, including acetaminophen and NSAIDs. We can also help our clients without medication, and this can include distraction, guided imagery, or even changing in positions. Semi-Fowler positioning can be very helpful and effective to decrease pain in our clients, as this decreases the pressure around the appendix. It is extremely important that we do not apply any heating pad or heat to the abdomen to help relieve pain. This can further exacerbate the inflammation and actually potentiate a rupture of the appendix. We also do not want to give any enemas or cathartics, as this can increase the activity of the bowel and cause a perforation or rupture of the appendix. This is a very important point, so remember these three things: no enemas, no cathartics, and no heating pads.
This topic is arthroplasty. Pathophysiology. Arthroplasty is the surgical replacement of a synovial joint with implants. Remember, a synovial joint is where two bones come together, but they are not joined. The joint is surrounded by smooth cartilage and contains a synovial lining and fluid for smooth movement in bending and moving. The most common joints replaced are the hip and knee, but I have seen the shoulder and ankle also replaced. Joint replacements can be total or partial. A total arthroplasty, or total joint replacement, is when the entire joint is replaced with implants. It generally will involve the two surfaces that come together in the joint. When it is a partial, it is called a hemiarthroplasty, as seen in the image here. The femoral component is implanted, but the acetabular socket was not replaced, making this a partial hip replacement, or hip hemiarthroplasty. A client may also require a revision. A revision is after a client has had a primary arthroplasty. This may be replacing all of the components or just some of them. Indications. Joint replacement is normally done for pain control and mobility improvement. The pain may have steadily increased and is now affecting the client's everyday life. Or the client's mobility may become limited and the client will seek out a solution. Causes of that pain and immobility include osteoarthritis. The cartilage is damaged, and this can be due to age or obesity. Osteonecrosis, the death of bone because blood supply was cut off, so no blood supply, no oxygen results in death. That could be from excessive alcohol use, long-term steroid use, or broken bones. Rheumatoid arthritis. This is an autoimmune disease that results in inflammation of the connective tissue in the synovial joints. Congenital anomalies. A baby born with functional or structural anomalies. Knee or hip fracture. You can see in the image two of some of the numerous areas the hip can be fractured. On the left, a femoral neck fracture, and on the right, an intertrochanteric fracture. There are also clients who have had previous arthroplasty, and the components have failed or loosened, and these clients require an arthroplasty revision, like we spoke about earlier. Complications. Infection. An infected joint can be detrimental for a client. It may require long-term antibiotics, a revision, and oftentimes, if the joint is infected, the surgeon needs to wait until the infection has cleared before placing new hardware or implants. Deep vein thrombosis, or DVT, which can lead to a pulmonary embolism. Older clients are at an increased risk for this, and that's generally who most joint replacements are performed upon. To prevent DVT, there are different interventions that are included in a client's care. The client should have proper hydration, early ambulation and exercises, and anticoagulant therapy. Clients may have persistent pain and swelling, which can then lead to limitations to function and mobility. This will affect their daily lives and possibly the ability to care for themselves. Age-related considerations. Older adults. The majority of clients undergoing total joint replacement are over 60 years old, and this age group is at higher risk for complications. They have more comorbidities. Older clients enter surgery with more comorbidities than would a healthy younger client. The older client may have hypertension, pulmonary disease, diabetes, kidney disease. These all affect them during the procedure and also during recovery. And they are on more medications, maybe anticoagulants, insulin, steroids, blood pressure medications. All of these will affect the client during surgery and post-operatively during recovery. Pre-operative nursing interventions. We need to check for signs of a current infection, like a fever. Due to the risk of developing an infection in the joint, most surgeons will not perform surgery with implants on a client with an infection anywhere in their body. We need to check the client's ability to learn and understand teaching. Did they follow the pre-op instructions, and can they follow the post-op instructions? We can help them identify a joint coach and include that person in the teaching. It could be a family support person or a caregiver. The client may meet with physical therapy to learn transfer techniques, proper use of devices, and to practice exercises. The client and caregiver learn these before the surgery. Then that information can be reinforced at the time of discharge. We want to teach infection prevention. They may be instructed to bathe the day prior to surgery and morning of surgery with a specific soap. We need to review current medications. Some may need to be stopped prior to surgery, and provide teaching for new prescriptions like analgesics. And we will administer intravenous antibiotics as prescribed, normally 1 to 2 hours prior to surgery. Post-operative nursing interventions. We will be monitoring all the things we normally do with a post-op client, with a couple extra focus steps. We'll monitor their vital signs and mental status. Are they stable? Are they waking up from surgery properly? Arthroplasty is done under different types of anesthesia: spinal, monitored anesthesia care, MAC, or general, or a combination. You need to know what type your client had. Check the operative site for bleeding and edema. And check circulation of the affected extremity, those neurovascular checks. Distal pulses, is the foot the same color and temperature as the other foot, sensation, capillary refill. An abduction pillow may be placed between the legs after the lateral or posterior approach is used for hip arthroplasty. A special pillow is placed between the legs, or a couple of regular bed pillows can be used. This will help the client avoid adduction. A common complication with hip replacement surgery is dislocation of the hip joint. This is more common with the lateral and posterior approaches because of how the surgeon gains exposure and access to the hip joint. With these two approaches, the client should avoid adduction to prevent dislocation. But dislocation is less common with the anterior approach, and pillows between the legs are not normally used for clients who had the anterior approach for a hip replacement. We will encourage the use of incentive spirometry. We will inspire the client to inspire, to encourage deep breathing, which will help prevent atelectasis and pneumonia. And we will implement mobility exercises as soon as possible and as prescribed, all those exercises they learned preoperatively, and we will reinforce whatever the physical therapist has planned. We will administer antibiotics, again to prevent infection. An infected joint can be detrimental for a client. Pain control with administering analgesics, and we can apply intermittent cold packs to the surgical site. Some clients will have cryotherapy, an ice circulation pad that is wrapped around the joint. Client teaching. We want the client to inspect their incision daily for redness, drainage, and swelling, looking for those signs of infection. We want to make sure that the client uses their assistive devices as instructed, like grab bars, raised toilet seats, walkers, and railings, to assist with mobility and activities of daily living, and to avoid complications or falls. They should avoid driving until approved by the healthcare provider, and adhere to the recommended mobility exercises and limitations. And when exercising, they should have frequent rest periods. We want them to do the exercises, but not to overdo it. In their home, they should minimize clutter to decrease the risk for falling, like removing area rugs and making sure walkways are clear of clutter. Keep up the great work. I'm proud of you.
This topic is atopic dermatitis, also known as eczema. So let's talk about the pathophysiology behind atopic dermatitis. So at the fundamental level, atopic dermatitis is an impaired skin barrier. This is a chronic and inflammatory skin condition that can ebb and flow, which just means it can come and go. With this impaired skin barrier, that means the skin is exposed to all the environmental elements, including allergies. So once the skin is exposed to allergies, they're able to penetrate through the skin barrier, and then the body creates immunoglobulins, antibodies, also known as IgE. And they then create an allergic irritant reaction. Clients with eczema or atopic dermatitis typically have elevated levels of IgE. This is why eczema is so common in clients with other issues such as asthma and allergies. The most classic presentation of atopic dermatitis are dry, scaly lesions with an erythematous border. We can also see papules form on the skin as well. Those papules can open and start to secrete a thin liquid that causes oozing and a thin crest. We may see different distribution patterns of atopic dermatitis of clients in different age groups. In infants, it's common to see atopic dermatitis all over the body, so we can see it on the cheeks, the trunk, the elbows and knees. In older children or adults, we typically see it more on the extremities, so the neck, more flexural antecubital folds, such as the inner elbows and behind the knees, and on the ankles. The most common complication of atopic dermatitis is lichenification, or just a thickening of that skin. We see this most commonly, again, in the skin folds and with clients with a more chronic disease process. The most common complication from eczema is secondary infection, and that's due to our impaired skin barrier. The skin is again exposed to all the elements, including bacteria and viruses. The two most common bacteria that live on our skin are staph and strep. Both of these bacteria can cause a bacterial skin infection called impetigo. With impetigo, we can see a classic golden-colored crest form around the lesions on the skin. The skin is also susceptible to viruses, such as herpes simplex 1. Herpes simplex 1 is the same virus that causes cold sores frequently. Eczema herpeticum is the type of secondary viral infection that can occur from herpes simplex 1. And as you can see in this photo, you may also notice a golden crest form around those lesions. Let's talk about how we can educate our clients with atopic dermatitis and what interventions we can implement to help them. Topical steroids are one of the most common treatments for eczema. Topical steroids can help decrease the inflammation and that intense pruritus or itching that's associated with eczema. Immunomodulators can also be used, and that can help create homeostasis of that skin barrier. Antihistamines work as antagonists for histamine-binding receptors, so that decreases that allergic response that we have when exposed to allergens. Skin hygiene is very important with the skin condition, as many other skin conditions. One of the most important things we want to do is prevent infection. We want to make sure that the skin is clean. While we are implementing good skin hygiene, we also want to make sure that we are keeping the skin moisturized. So we do want to keep bath or shower time limited to about 10 minutes to keep the skin from further drying out. We also want to educate clients to use moisturizing soaps and soft, gentle soaps. After bathing or showering, we want to pat dry gently and then possibly allow time to air dry as well. Immediately after patting dry after bathing, we want to apply an emollient to the skin. This will help seal in any moisture that we just got from that bath time. We also want to tell clients that they should wear breathable, permeable, possibly cotton fabric clothing after applying the emollient. This is to ensure that the skin is able to absorb all the moisture it can. So also educate clients that they can wear long sleeve and long pants to help the skin absorb all of that moisture. As with any skin condition, we want to educate our clients to have short, trimmed nails. This is to prevent any further infection if they are to scratch and open up those lesions. Avoiding triggers is also very important to help decrease the exacerbation of eczema. So we want to make sure that since the skin is already dry, we try to avoid dry or low humidity climates, as well as avoid any high heat climates. As we discussed, the skin is going to be very itchy and these clients will be scratching. So we do want to educate our families to monitor for any secondary skin infections. Signs and symptoms they need to report immediately to their healthcare provider include increased redness, swelling, any drainage, and fever.
This lesson is about bacterial meningitis. Let's talk about the pathophysiology. Bacterial meningitis is life-threatening, and it's inflammation or infection of the meninges, which is that covering over your brain or spinal cord. Think of it kind of like plastic wrap that you would put on the leftovers of your food. It's going to hold everything tight and keep everything together where it's supposed to be, no spills. Typically, meningitis is caused by Neisseria or strep pneumoniae. Let's talk about clinical features, which really means cues. You always want to look for cues or abnormalities in your patients. There's a difference between adults, pediatrics, and neonates, and you also want to know early versus late cues. We want to protect our patients and catch these things early, catch those abnormalities early. With adults, you're looking at fever, headache, vomiting, and you see that with pediatric patients too. But with adults and later signs, you're going to see neck stiffness, Brzezinski, or Koenig sign, which we'll talk about in the next slide. Pediatric patients, you're going to see a rash. And neonates, that early sign is going to be poor feeding, or you might see poor suck, or perhaps bulging fontanelles from increased cerebral edema. Here's a great slide that differentiates Brzezinski sign versus Koenig sign. Now you'll notice that Brzezinski sign starts with a B. Well, whenever you bend your patient's neck forward, you'll see that their knee will actually flex because of how inflamed their spine is. Versus Koenig sign starts with KE. So think of knee extension. We're extending our patient's knee, but they can't do it because of pain. And again, it's from inflammation. Both later signs of bacterial meningitis. Diagnosis. So now we're going to analyze those cues. Typically, bacterial meningitis is diagnosed from a cerebral spinal fluid exam or a lumbar puncture. Now, we'll talk about that in the next slide. It's going to be cloudy. Think of a UTI. It could be cloudy when you have a UTI from bacteria, so that makes sense. You're also going to have a high opening pressure. What does that mean? It means when the physician is doing the procedure, there's so much pressure in their spinal cord that it's almost like shaking up a soda pop can. You're going to have a high WBC count. Why? Because of infection. You're going to have a high protein because of inflammation always means protein, and low glucose because bacteria always want to eat sugar. You'll also have a positive culture that's going to let us know which type of bacterial meningitis this is. What are complications? This is what we're protecting our patients from and how you are a safe new grad nurse. We're protecting them from increased intracranial pressure. Think of brain tissue ischemia. What is ischemia? Lack of blood flow. So we're thinking of damaged brain tissue. Your brain can herniate. There's only so much room in your cranial vault. It's 80% brain, 10% blood, 10% cerebral spinal fluid. You only have so much room in there, and when you have too much pressure, your brainstem will herniate. This leads to permanent functional impairment and intellectual and behavioral difficulties, even seizures. If the patient even survives, they end up with hearing loss, and eventually they can die. So what is our job? What nursing intervention or actions do we need to do for this patient? Well, you know they had a lumbar puncture, so we're going to have to monitor that site, make sure they don't bleed. You guys know surgical interventions. You're going to have to give them antibiotics, make sure you're giving them on time. Definitely look for side effects like rash. They're going to be in droplet precautions, especially for Neisseria. We need to decrease that environmental stimuli. Why? Because they have increased intracranial pressure. We have to be quiet. We have to cluster our activities with this patient, not overstimulate them. Think of when you're angry or when you cough. You want to keep everything calm. Frequent neurological assessments, especially when it comes to cranial nerves. Keep that head of bed up 30 degrees, neutral neck. And future prevention, don't forget, guys, that vaccination is not just for the patient, it's for their family. So what interventions are we going to do? We have to make sure not to forget seizure precautions. Seizure precautions, you always start with your ABCs, airway. So you want what? Wall suction on. You want to make sure that they have oxygen. You want to keep them safe. That is your job as a new grad nurse. Great job, guys. You did great on this lesson.
This topic is bariatric surgery. Bariatric surgery refers to any invasive procedure that is meant to treat extreme obesity. The goal of bariatric surgery is weight loss. It is important to note that the surgery alone is not enough to ensure weight loss. The client must also be prepared to implement changes in diet and exercise to aid in and maintain any weight loss. Bariatric surgery is indicated for clients with a body mass index, or BMI, greater than or equal to 40 kilograms per meter squared, or for clients with a BMI greater than or equal to 35 kilograms per meter squared with at least one weight-related comorbidity, including cardiovascular disease, hypertension, obstructive sleep apnea, and type 2 diabetes mellitus. Prior to approval for bariatric surgery, the client must undergo appropriate screening for conditions associated with poor surgical outcomes. Screening for certain psychological, physical, and behavioral conditions can minimize the risk for complications following surgery and help to ensure weight loss success. Psychological conditions that can lead to complications include untreated depression and binge eating disorders, which can lead to overeating and decreased physical activity after surgery. Physical conditions that reduce life expectancy, such as advanced cancer and irreversible heart disease, are contraindications to bariatric surgery, as these conditions are unlikely to improve with surgery and weight loss. Behavioral conditions that are contraindications to bariatric surgery include drug and alcohol use disorders, as these can minimize a client's commitment to lifestyle changes following surgery. Bariatric surgery is classified by how it affects the digestive tract. Restrictive bariatric surgery works by decreasing the size of the stomach, while malabsorptive bariatric surgery works through bypassing the small intestine or reducing its length to reduce the amount of calories absorbed into the body. Certain types of bariatric surgery may be a combination of restrictive and malabsorptive. We'll discuss different types of bariatric procedures in the following slides. Again, restrictive bariatric surgery reduces the size or the amount of food allowed into the stomach. We see examples of procedures that are restrictive in the image on this slide. Gastric banding, which we can see on the left, is a procedure that places an inflatable band around the fundus of the stomach. This band is inflated to a prescribed pressure, which creates a small gastric pouch above the band and causes the client to feel full after ingesting a small amount of food. A sleeve gastrectomy is a procedure that removes up to 75% of the stomach, creating a sleeve of stomach that again makes the client feel full after ingesting only a small amount of food. Next, let's talk about the combination of restrictive and malabsorptive bariatric surgery, where the size of the stomach is reduced and part of the small intestine is bypassed. A Roux-en-Y gastric bypass is a two-part surgery, which we can see in the image on this slide. If you'll notice, an incision is made to split the stomach and form a gastric pouch. This gastric pouch is then connected to part of the small intestine, which bypasses the duodenum and